Okay, thank you, Carol, and thank you for having us. So my first question is actually to the audience. I'm wondering how many of you are public health people like I am. Just raise your hands. So several people in the back. How about community health workers? Anybody identify as a community health worker? Okay, a couple people. All right, great. So the moment you realize you should have printed in larger font. So I want to just make some observations, things that I noticed throughout the film, and then turn it over to Betsy and Eliza to answer a few questions. The role of access, and specifically primary care, was really noteworthy to me, how crucial that was. And the Alma Alta conference, I had never heard of that before. Anybody hear of that before? News to me, and the quest for health care for all. And to see that that was crippled by wealthy nations, that was a really important theme throughout the movie. And just, something to think about is what does that look like in the United States and what does that look like here? And I think a related theme was how poor planning of a development project led to flooding in Haiti and displacement of people. And again, poor people, bias against poor people. How does that play out locally? What do we observe? Just some things to think about. One of the more positive themes in the movie, how do we use our privilege and our connections? So we don't all have a Tom White in our lives, although we wish we would. But how can we use the connections we do have? And I'm not advocating stealing from the hospital pharmacy, in case our hospital president is here. But to do what we can to find funding, to change attitudes, how can we use the resources that we do have, even if they're not enough? A quote that I really liked, make sure what we are doing is ambitious, so ambitious it makes people uncomfortable. That really stood out for me. And then lastly, the need for keeping one sense of humor. This can be tough work. Certainly not as tough in Amherst as it is in Haiti, fortunately, but nevertheless some challenges. So with those observations, I want to pose a question to Eliza and Betsy. And tell us, what is a community health worker? Start with you.
Thank you very much for having us. So community health workers, in the way in which we have used them for about 10 years or over 10 years at the Community Health Center, are people from the community with shared life experience as our patients, who we don't require that they have any training or any background, but just a commitment to helping their community and obviously interest. And we provide them with training, and they go out. They work with our providers, our medical providers primarily, but in fact any of our providers, because we also have dental and optometry and behavioral health, and they work with them to develop, to work with patients on their own health goals. So they will help them with thinking about nutrition, about how they can make sure that they get their medications. But then, I thought when Dr. Farmer talked about that people will say they want a hospital, but they also want housing, and they want education, and they want food. Those are all things that we at a health center are really committed to have always, for the 70 years we've been in existence, have been really committed to helping people with. So community health worker will help that person connect with housing, with food stamps, with whatever the resources they need, which are called social determinants of health, which has a fundamental impact on their health. And they go for walks with people, they help people with transportation, which in the hill towns is an enormous issue for low-income folks. They do what needs to be done, and they're supportive, and they are there. So I think that's the most important thing.
Before Betsy speaks, George, could you just turn up the lights in the rest of the auditorium so we can see you and it's a little easier?
So Eliza answered my next question pretty much, which is, there was a quote in the movie, how do you make social justice real on the ground? So as you're answering, Betsy, if you could give us some examples from your world of how you do that.
Thanks for asking the tough question, what's a community health worker? We used to, a Positive Place of Hampshire County, some of you might remember the name AIDS Care Hampshire County, which provides services for folks who are positive living with HIV and AIDS in our 3 counties now. We opened our doors in 1991 with a go-getter, pretty much like Paul Farmer, somebody who was determined to support folks who were dying without dignity at the time, and a couple of what he called case managers. who had been working with folks dying with AIDS for about 10 years already. They opened up the store in 1991 with those few people, and over the years, we began to build a much larger cohort of what we now call community health workers. Most of you know that nowadays you can control HIV and AIDS with 1 pill a day. Some of you might know that we can actually begin to prevent the risk of transmission with 1 pill a day. But we still see some of the impacts of what we might call globalization here in our own backyard, still impacting the lives of many of those who are most at risk for not just acquiring the virus of HIV and AIDS, but not being able to sustain a health and rich life as they should. The people who carry the highest burden, might not be surprising for you to hear, are Blacks and Latinos, transgender women, and intravenous drug users, many of whom started to use intravenous drugs because they were given painkillers in the early days for their co-occurring disorders with HIV and AIDS, which now are no longer given out so quickly. So they turned to some of the drugs on the streets, which will help with their pain and their trauma. To come back to the question about what our community health workers do, I'll say they do everything that Eliza mentioned for hers for the past at least 10 or 12 years. They come from the community. They come from the communities that are most, who carry the highest burden and that have been impacted the most. They listen, they drive, they go to the barber with folks to have great conversations. They advocate. They withhold judgment all the time. And sometimes that's very difficult. We get very frustrated with folks and the system because having access to these meds and having access to a doctor isn't all that you need to have. As Liza was saying, we need access to housing. We need access to recovery coaches and healing from trauma. So what we began to do at A Positive Place was to build a cohort of community health workers who didn't just come from the Latino community and the Black community and the intravenous drug community, but we gave them specific sort of specialized functions, and we became an interdisciplinary team. So we have a recovery coach from the Latino community who also is formerly incarcerated and homeless, who deals with some of the most difficult situations that come up for patients who are in similar situations today for lots of reasons that derive from the impacts of globalization, if you want to put it in a nutshell. We have a housing advocate who everybody knows in the Western region can get anybody housing. She's Latina. She lost 6 brothers and 2 sisters to AIDS in the 90s, who came to our services at then AIDS Care Hampshire County. We have a resource coordinator that makes sure everybody has income, drug reimbursement, and health insurance, on and on and on. We work closely, again, as we saw up in the hill towns and here at the Masanti Center, work very closely with the HIV specialists and some primary care physicians around disease management. Just wanted to reiterate that access to drugs, access to health insurance, which we all have in the Commonwealth, often isn't enough, especially for folks living with HIV, and I'm sure you can talk about other situations as well. But we do have to tend to the social determinants of health, which Eliza was referring to: housing, transportation, education, employment, and that's what we do.
So let's stick with you for a minute. Hang on to the mic. And I want to explore for a minute the role of serendipity. Paul mentioned that in the film, and it really struck me. And I was thinking, do we really need somebody like a Paul Farmer, an Ophelia Dahl, a Jim Kim? Or can we do this ourselves? And what if you don't have a Tom White in your lives? How do you actually do what you need to do? How do we make that happen? That's a tough question.
You asked me that first because, well, frankly, luckily for us in the U.S., we don't have a Tom White, but we have a Ryan White. Some of you might have heard of Ryan White funds that are appropriations through the Congress that support people living with HIV and AIDS, and that's how we do the work in the U.S. We get annual appropriations for treatment and for prevention. So we have a Ryan White that comes through the federal government, and it trickles down through our state through the DPH. We never have enough to do the work. We're always learning from the community health workers, new ideas from our patients that they're working with, and seeking ways to pay for that, because we never have enough through our funds, which are all grant funds, to do the work. I'm thinking of an example, and I'll just give one, about one very dear to us, 60-something-year-old woman who'd been living with AIDS for many, many years, also Hep C, also diabetes, pretty common co-occurring disorders. She had led a life of working the streets and had gotten the virus through HIV drug sharing of needles and things. But she had been a longtime client of ours. We'd worked with her for years, go to her home. She had gotten very sick, and there were a bunch of young women who were working the streets who were sort of tending to her as well. And over time, our community health workers who would go into the home, and not many other people would, I think they had sent the VNA and Hospice of Holyoke out to them, but they stopped going because they felt it was too dangerous, because they were active users. They were pretty respectful and didn't use when we came, but we knew what was going on, and we were desperate to figure out how to get them tested, and desperate to figure out ways to see if we could lessen the amount of use or help them figure out why they're using and to stop using, whatever the case would be. We told them about syringe access places. We told them about the anonymous testing and counseling places like Tapestry, and they wouldn't go because they don't trust anybody. They don't trust healthcare systems necessarily. They don't trust social service agencies necessarily because they're active users. They're drug addicts. And what do we think of drug addicts? People who are homeless. What they finally made us realize is that we need, since they know us and they trusted us, and it could have been any us, but it happened to be us, community health workers who were there, that we need to test them. Here's the sad part about our funding. Like silly things that we heard happen here. We're only funded for treatment and healthcare services for people who are positive. We're not funded to test people. So we wrote to our funders and asked if we could, be tested for this. In the meantime, we got a couple of our community health workers. We sent them through like phlebotomy classes at our hospital, where a program of Cooley Dickinson got all ready to start a whole new way of doing the work that we hadn't thought of before. And the idea came to us from the very people that we were working with and trying to help. And we didn't get the funding. Ryan White didn't come to our rescue. No Tom White came to our rescue. And that brilliant model, a new model of service delivery, didn't happen. The community health workers knew what we needed, but the funding wasn't there.
So let's pass that over. There were a lot of special people, a lot of special moments in that film, and Father Jack was certainly one of them. And when he died, Paul said, "Tell me this is not my responsibility," and talked about the delay and how that mindset leads to tragedy in this case. And Eliza, could you talk a little bit about what happens locally? How do we get past that mindset and past that delay?
Softball question.
I mean, thinking about it locally, for me, and maybe it's because I'm a big picture thinker, is difficult because I think that so many of the barriers that we face are not necessarily local. And when I think about community health workers, I mean, you see this movie and you think, obviously, health systems around the world are recognizing the incredible importance of using community health workers. Obviously, we must, in Massachusetts, which is known for being, the locus of the most incredible healthcare in the country, obviously this must be a priority that is accepted in this state. But in fact, we cannot get funding for community health centers in Massachusetts on a reimbursement basis. Community health workers, what else? Right. Yeah. Health centers. Oh, no. We have funding for community health centers. For community health workers, we have to rely on grants, which are unstable. We have to rely on fundraising that we may do, but we can't actually bill anyone for those services, even though they are crucial to the maintenance of people's health and sort of even more fundamental than primary care, but an important part of primary care. That isn't something that has yet been prioritized by the healthcare system. And it's on its way. The state has been working on it for years. in terms of getting the certification regulations completed and then how the reimbursement's going to work and all of that. I think, so when I think about delays, I mean, I think I mean, to sort of take Betsy's example, there are great models, and in order to get them in place in a sustainable way, it takes an incredible amount of time. And that is a function, I think, of a healthcare system that, unlike in Rwanda, where they were building a healthcare system from the ground up and they could put community health, keep saying it, community health workers in, from the beginning, we are working from a system that started in a really different place. And what makes me very happy about working in a community health center environment is that we have prioritized those issues from the very beginning. And in fact, I find it very interesting. Community health center, the idea of community health centers actually came to America from South Africa, from Soweto, and was created as a model first in Boston and in Mississippi. And we've been doing this forever, and the health system is finally, I think, coming our way, but it is slow. And so that is a delay, and I feel like the issues that they were dealing with in this movie are so much more extreme than what we deal with in this country, except for individual people who do deal with those situations, but it is a system. But those delays still cost lives, and that is frustrating.
Okay, so let's stick with you for a minute. In the film, during the portion of the film where they were talking about AIDS, someone gave the example where community health workers will go to someone's house 6 times a week for up to 2 years, which is just unimaginable to me. You've talked a little bit about what community health workers do, but can you talk a little bit about how often they go and would we really do that 6 times a week for 2 years?
So I think my sense is that Betsy's folks do that, and I think our community health workers work with people in ways that, every person's different in terms of what they need. So we have a healthcare system that is relatively accessible, certainly in comparison to that. So our community health workers are working on supporting clinical care, but they're not taking medications out to people necessarily. They're not taking food to people. So we're not at that level of intensity. I don't think so, no. But it is a sort of constant presence, and I think they do what they need to do for individuals based on what their self-identified needs are. That's a lot of it, is working with people to not tell them what they need, but to ask them what they need and to work with them to make sure that those needs are met.
Yeah, and I just want to say I painted quite a picture of doom and gloom, and I want to say that because of the work of the community health workers at A Positive Place, working in partnership with other medical professionals and others in the recovery world, et cetera, we have exceeded state and national goals for linking patients to care, keeping them in care once they get connected, getting them on antiretroviral therapies and treatments, and getting them to an undetectable viral load, which means that you're pretty healthy and you're not going to transmit the disease. So, the work that community health workers do when they go out 3 times a week, we don't go out, 6 times a week, but we work, 8:30 to 5, and people are out often, not always just sitting around. Some people come to see us in our offices, and I think they do make the difference. I still think, the way they were talking about in the movie, it is about people in poverty. It's also about black skin and brown skin, and those are big systems to bust. We can talk about resources and putting somebody like Dr. Kim on the World Bank, but we have to, and I think it's fair to say we need to start chipping away at some of those other, isms that really impact a lot of our patients.
So in the film, I'm going to switch topics just a little bit. They really focused a lot on drug-resistant TB, and in Peru, they talked about being told, if you treat a single patient, we will kick you out. And then a colleague's daughter got sick, and they treated her, and then they were able to treat more patients. And this is kind of an impossible question to ask, so I'll send it over to Betsy first. But
Give it to the audience.
so do you have to have a connection, special connection, to get that kind of treatment? And I guess locally we probably don't, but can you elaborate a little bit on how that might play out here?
Not so sure that you need to have, a personal connection, although sometimes it does help. But I think you need to have some connection to the knowledge and the way that cultural systems work in our system. You have to have the language in order to, be able to access the medication and the treatment. So I think in that sense, I'd say, yeah. What do you? I see you shaking your head.
I mean, I just think access is, to me, all of the whole healthcare system
Yes.
boils down to access. And is it poverty? Is it transportation? Is it language? Is it race? I mean, those are huge issues. And so I always tell people, here we are, we're up in the hill towns, we're in Worthington and Huntington. Nobody even in the valley knows where that is, or many people. But we have people come from 100, I think we're up to 122 zip codes come to the hill towns. So no public transportation, because they don't have access to services anywhere else. Because particularly dental care, there isn't a place where if you don't have dental insurance, you can go and get your fillings and your crowns and your dentures done, except at a community health center. And so I think, do you need to know someone? Not necessarily, but you need to have a place where someone will take you. You need to have the ability to advocate for yourself and to go to those places and to get the things you need. And if you don't, it's been very interesting for us to come into Amherst and serve a population that's very different from who we see in the hill towns. But learn about that there are people who are very isolated, even in a community that, is not, it's invisible, I think. And to be able to get that access, I think is just, that's sort of, for me, that's what it boils down to. And it just reminds me, I know I'm maybe talking too long, but you talked about the serendipity, and I feel like, I think Ophelia Dahl mentioned it, they had unbelievable privilege. Paul Farmer and Jim Kim and Ophelia, that they had a Mr. White, because somebody at Harvard, I'm sure, introduced them to him, and that they could do those things. And to me, sort of what's so important about community health workers is it's giving people who may be just as brilliant and just as capable, but do not have access to those resources, an opportunity to do something for their community. And I really hope that when we hire a community health worker, that is not the last job they have, and that this is an access into a system, and that they will then take that somewhere. It is such an exciting model. We can't all build universities to train people, but we can do that.
So how about one more? Can I do one more? One of the themes in the film, and focusing on the Ebola situation in Africa, and the theme was creating a healthcare system that is responsive, and it seemed like they had done a really good job there, and they had done it just in time. So even if there is an Ebola outbreak, that they would know what to do, and it was pretty clear they were able to execute. And Paul says it's not rocket science, but it does take work, it takes planning, it takes money. So Eliza, can you tell us how we are prepared locally? How are we doing with that?
Oh, I think that besides the federal mandates that we be prepared, that I think that there is good communication and there's systems. We're primary care, so in those cases, our job really is to get people to secondary and to the hospitals. But I have to say, this week, in thinking about public health, my biggest concern is, the issue of, and I don't know how many of you read about this in the news, but there's going to be a change in how they look at people's immigration status and applications for green cards, and that people will be considered public charges and therefore not as eligible if they get Medicaid or WIC or food stamps or anything like that. And I've been following this for a couple months, and the fear is that people are going to just drop out of those programs because they'll worry that it's going to affect them. That is a huge public health issue. If you have huge groups of people who are not accessing healthcare out of fear, either because they're worried they're going to be deported or they're worried that that they won't be able to be eligible, that's going to be a public health issue, because then we will have TB that is not getting identified and treated, or Ebola is sort of an extreme case in that case. But so that's the kind of public health thing I think we also have to keep in mind. Just not just do we have the doctors, do we have the systems to address it, but how are we going to make sure that we don't even get to that spot? So.
Turn it over to Carol.
Do you have anything you want to add,
I just
Betsy?
wanted to say, in some ways it's not Ebola, but we have an opioid epidemic. We have a Hep C epidemic.
Hep A in the state
Hep
right
A
now.
now also. And the question, are we prepared? I might actually turn it over for 1 second to Jeff to talk about how we were prepared for the opioid epidemic and what we were able to put into place in Hampshire County.
Sure. I think we're never as prepared as we need to be, especially when we're talking about behavioral health-related things. And I think stigma plays so much of a role in that. But I think we are getting better and better prepared for it. I think one of the really eye-opening aspects to the opioid crisis has been who is affected. And when it seems to be white, middle-class, and upper-class kids, it gets more attention. And I think that that's unfortunate, but it just needs to be noted. We are doing a lot in Hampshire County. We have the Hampshire Hope Coalition, which stands for Heroin, Opioid Prevention and Education, that we're part of. We've been doing a lot at Cooley Dickinson around this initiative, better training, better screening, having physicians more and more prepared to prescribe what's called buprenorphine, or some of you know it as Suboxone. So things are getting into place, but we are still seeing way too many people die. And the crisis keeps changing. Just when we think we might be turning a corner, all of a sudden, heroin is now laced with fentanyl. And it is so much more dangerous and so much stronger than it was even a couple of years ago. So continue to chase it.
I just want to say that as a layperson not working in medicine, I'm really inspired by the passion that you bring to the topic and the obvious confidence that you have and the insights that you have into how health care and larger issues affect all of us. And I just really appreciate your being here. Are there questions from the audience now? Yeah.
Not so much a question as just I'm inspired by everything that you're doing, as I have been inspired by Paul Farmer since I read Mountains Beyond Mountains many years ago. I did want to mention one thing, Betsy, that you said when you pointed out a specific hospice not visiting a patient because she was an IV drug user or he was an IV drug user. I think that was ill-advised. I'm very familiar with Polio BNA Hospice, being married to the manager of that agency, and they visit folks who are active drug users every single day. So I would just caution you on sharing that kind of information without really knowing.
I apologize for that, and I should say that it was a bit more dangerous than just the drug use at the time. And they did try and go in. It didn't work out, but I apologize. I take that to heart.
Other questions, comments? Well, this is not like our usual audience. It's usually very inquisitive.
We're stunned by Paul Farmer.
Yeah.
Can I just say that it is a little intimidating to be speaking after? Truly extraordinary.
Yeah. Yes.
I, like everyone, am inspired by Paul Farmer and the other people he worked with. But I also think it's important to remember, and I find it somewhat inspiring, that they didn't know where they were going to go to. They didn't know they were going to create this incredibly huge organization and impactful system. And the idea that they said, well, let's just focus on this one town in Peru. And whereas sometimes I feel like, my God, if I can't solve all of South America's problems, how do you start? And so this idea that they started very small and felt really good about that and then built from there. So I think there's a lesson from that to not get overwhelmed by the enormity of the problem. And you run a health center here and a positive place there, and Jeff and his Hope work. And that all those little programs, we might not be Paul Farmer, but all those little programs make a real difference.
And I'll just share a quick thing that we learned from community health workers. It's something that we say in the office, that we've learned to measure success differently in a lot of the work that we do. And there's a lot of joy and there's a lot of humor. There's a lot of hugging and there's a lot of laughter because we have done so. Thanks.
And there's so many folks, so many unsung heroes doing such great work. I'm thinking particularly around food systems and the residents of Hampshire Heights in Northampton, and the way they've really come together to organize. They now have a mobile market coming to them. So they may not ever be on a documentary, but they are out there doing great work and need everybody's support and encouragement.
There was a question in the back? Yes.
So, I guess I was wondering more about what we are not seeing here in Hampshire County, in terms of what the problems are, places where there's just intractable problems. And it seems to me that the opioid crisis might be one. I mean, I remember going to support groups for parents who've lost a child, and it stunned me to see that 3/4 of the parents were parents who had lost a child by overdose. And so I feel like it's one of those places where we don't know enough. Like, we live in a very comfortable area, but it's happening right here, and we still don't see it. And what can we do more?
Did you all hear the question? No. It was basically, what are we not seeing in our own area here? And what can we do?
I think, as I mentioned, I mean, I think that there is, on the one hand, Hampshire County has incredibly good health numbers compared to even our neighbors, to the south or in the rest of the state. I mean, so it is a hard conversation to have in comparison to the kinds of poverty we're talking about in the movie or even in other places in this country. On the other hand, there are people who I think are not, as I said, not visible. That there is real poverty, both in the valley and then certainly up in the hill towns, and I think behavioral health. Jeff mentioned behavioral health as an issue. I mean, I think that is a huge, huge unseen issue where people don't. We have a lot of behavioral health in this area, but it is not necessarily accessible, and I think that is a huge need, and it feeds into, in a very big way, into the opioid crisis, into other health outcomes. I mean, it is just, it is foundational to people's health. So, I think if you look at the numbers in Hampshire County, there's a lot more need in this county than is obvious when you're in the middle of the cities, the towns.
I'd like to add two quick things. One is, I think it's a lot harder to be poor in a relatively wealthier area because the services just aren't here in the way they might be in a more urban and poor area. And the other comment I want to make, there's a quote I really like. It's called, health is a byproduct of a community that works. So in other words, rather than chasing health, try to work together, engage with each other to figure out what kind of communities we want to be. And if you do that successfully, health will naturally occur. And I think we know that not everybody feels connected. Some people do feel isolated and maybe on the outside looking in. And that's when bad things, health-wise, can begin to happen. So if there is one thing we could all do, it would be to reach out to your neighbors, make connections. If you know there's a kid in your kid's school who's being bullied, reach out, make that connection.
Well, I think we'll just end it on the note of we can all just do one thing. We can all do our part. Thank you very much for being with us tonight.
Thank you.